Hello and welcome to today's webinar, Accessing Health Insurance Through the Affordable Care Act, hosted by Wider Opportunities for Women's Economic Security for Survivors Project. My name is Sarah Gonzalez-Kosinski, and I am the manager of the Economic Security for Survivors Project here at WOW, and will be moderating today's discussion. Before we begin, I would like to do a little housekeeping. Your lines have been muted to ensure that background noise does not interfere with the presentation. If you have questions or technical problems, please use the meeting chat box located in the bottom left corner of your screen to contact the WOW administrator. Following the presentation, we will open up phone lines for questions. If you have questions during the presentation, you can use the meeting chat box to send them to us, but we will hold them till the end. For those of you who are not familiar with us, Wider Opportunities for Women is a national research, advocacy, and technical assistance organization located in Washington, D.C. Our mission is to build pathways to economic security, independence, and equality of opportunity for women, families, and elders. Our work promotes policies and practices that increase job quality, improve gender equity, and empower women economically. As part of these efforts, WOW's Economic Security for Survivors Project provides training and technical assistance on how to address the economic consequences of intimate partner violence, sexual assault, and stalking so that survivors can be safe and recover from abuse. With enrollment period for the Affordable Care Act now being open, it's important that advocates, service providers, and consumers know what the ACA is, what the health care options it provides to uninsured are, and how they can get covered. Whether you work with survivors, low-income women, or other uninsured adults, this webinar will provide you with the information you need to connect the uninsured to these new resources. Affordable comprehensive health care is an essential part of economic security. Families are struggling against the increasing costs of health care. Research has found that individual health care spending has increased by nearly 75% since the year 2000. WOW's own basic economic security tables are a measure of a family's income needs based on their family type and the local costs, reveal that individuals without employer-based health insurance pay approximately 11% of their budget on health care. This is their fourth largest expense. So it's no surprise that health care costs are becoming increasingly burdensome for families. For those without health insurance, this often means delaying or foregoing care, which can lead to more significant and costly health care needs down the road. For individuals experiencing intimate partner violence, sexual assault, or stalking, the inability to pay for the high cost of care can prevent their recovery from the physical and mental effects of abuse, making them vulnerable to further violence, especially if they are dependent on their abuser for health care. To get a sense of which women are in greatest need of coverage, let's look at some research from the Kaiser Family Foundation. Their analysis found that nearly 40% of women living below the poverty line are uninsured. Minority women, particularly Latinas and Native Americans, are uninsured at high rates. And those without a high school diploma, who likely are confined to low-wage jobs that do not offer health benefits, are more likely to lack health coverage. Now that the enrollment period for the ACA has begun, how can we help these women access health insurance? To answer this question, we turn to our guest today, Amber Calvillo, Deputy Director for Women's Outreach and National Partnerships for Enroll America. Ms. Calvillo develops campaigns and programs to educate and enhance women around healthcare coverage while working with national partners in mobilizing people to get covered. With over 7 years of experience, she has worked in developing leadership programs and initiatives, working to empower women around various issues and campaigns. We are thrilled to have Amber here with us today and are really eager to learn about how we can help the people we serve access the important health care coverage they need. So at this point, Amber, I'd like to welcome you and turn the presentation over to you. Amber, can you hear me? If you hold on one moment, I think we've lost our guest speaker.
And can you hear me?
Yes, we can hear you now, Amber.
Okay, I'm sorry. I did this whole beautiful thank you speech. Thank you so much. So just let me know via chat if for any reason you lose me. I'm not sure what happened. But thank you so much for having me. I'm really grateful for this opportunity, and I hope that I can get as much information out there. So we'll get right into it. Today I'm going to be presenting on behalf of Enroll America and just give you some more information about the kind of work that we do in the, hopefully the role that you can play in getting the word out. So just briefly, I'm going to start by providing an overview of our organization, what we do, kind of set the stage on what your role can be and what the enrollment opportunity really is. So Enroll America's mission is to maximize the number of uninsured Americans. We are mission-driven. We are a nonprofit, non-political organization, and it's a twofold, really basic strategy, and all of our efforts that come out really revolve around these two. We promote enrollment best practices, and I'll go a little bit deeper into our departments and how we do that. We launched a national enrollment campaign using a lot of different strategies and research that I'll describe in just a little bit. So how this campaign fits in is we know that the successful implementation of the ACA is going to require all-out effort of nonprofits, hospitals, organizations that have really been working on the ground to get this passed for many, many years. We want to partner with everybody, make sure all the voices are heard, and it's going to require a lot of effort by a lot of people. And our National Education and Enrollment Campaign is a three-step process. We want to educate and engage people, and of course it's two audiences. We want to raise awareness to the uninsured and individuals or partner organizations that can reach the uninsured. We want to educate and motivate them to enroll using research by identifying messages and tactics that have been proven to be most compelling to each group, and then identifying partners and that can help us identify barriers to enrollment. What are partners already seeing that are some of the barriers to reaching the uninsured, and then help help them have the right messages so that they can disseminate the right information and the facts and support our partners by giving them the best practices to enrollment. And so the campaign has different strategies and tactics. Of course, as I already mentioned, we have strategic partners that I'll go ahead and briefly show in a little bit. We do a lot of community engagement. We have a strong, really aggressive grassroots effort, and I'll show you in what areas we're in. Everything that we do is powered by data, so everything is data-driven. We have a really strong model that can, to 99%, identify in what neighborhood the uninsured live, in what homes, so that we're, doing stronger canvassing, stronger outreach. We have an aggressive earned media. We have a great communications department, and just really trying to get people in their homes, getting the messages from the news outlets that they trust, radio interviews, different things. We have a great social media campaign, and we work with a lot of partners that are strong in that effort so we can reach different populations that aren't already activists or involved in our campaign. We're about to launch a paid media campaign that is actually going to target lower income women, and so really specifically Latino communities and Black women. And then we work with surrogates, and surrogates are just people that are already identified as trusted messengers in the community, leaders, somebody that is trusted that we can give the key messages to that can help us get the word out. So this is some of the sampling of our strategic partners, just a very small list. But it gives you an idea of just the wide range and the gamut that we have, from big organizations to organizations that just work with young people like Young Invincibles, CVS. We've been tabling in their stores. And each partnership works different. We use the strengths of the organization. So we do just a variety of things with a lot of different partners. And then just to set the stage a little bit, I'll give you, this is a map of where we are present. The highlighted states, let's say staff on the ground, is where we have a field team. So we have a state director, we have organizers, a field director. So we have an office. It's more of a presence. And in California, we have 2 staff, but we will not be having an aggressive field campaign there. And we're still hiring in Tennessee. And then in the lighter states, we're working with partners. So we have a state assistance team, and we have regional managers that work to identify coalitions that are already existing, so that we can work to give them resources, key messages. And so we work with a lot of partners. We rely on a lot of coalitions and partners that exist in those states. So this is just giving you a glimpse on how far we reach, but really how we can work with any organization or partner. And just to clarify, and the people that we have on the ground, the staff, the highlighted states, these were based on the higher density of uninsured populations, and this is kind of how they chose the states that we were going to be in, and states that weren't going to have a lot of support economically to help get the word out. So usually states that didn't extend Medicaid. And so I'll go into section 2, and this is I'm just gonna cover like the public awareness of new coverage. What kind of messaging are we using? What you should be saying when you talk to people, and a little bit more about the timeline of enrollment and some eligibility. So just to get an idea, I don't know if we might be able to use the chat feature here. But what percentage of uninsured people do you think know about the new coverage options coming this fall? And maybe you all can type in the chat box, just kind of an idea of how many people you think are still unaware or know about the new coverage options. Okay, so I see everyone less than 5, 10, 30. All right, so kind of under 45, right? Almost everybody's answers are coming in. Awesome. So kind of close. So we're increasing awareness. We see a good peak, but we know that there's still a lot of work to do. So when we started, you can see in November 2012, 22% of the uninsured were aware of their options. So these were people that were eligible for new health insurance, whether that was they were underinsured or uninsured, 22% knew. And then we saw it rise in the summer, and now we're at 57%, which is good. I mean, that number has increased a lot. That means that our job is doing a good job, but then also all of the organizations that are working to get the word out, everybody's doing a good job, but we know that there's still a lot of work to do. And so in past experiences, when people have looked for coverage, what our national findings and in our research showed is that, the typical things that you would feel when you are unaware of all of your options, but you have to do it. People feel stressed, they feel overwhelmed, worried, confused. These are the words that came up the most in focus groups and interviews and the research. Like, how did people feel when they were seeking coverage? 44% have shopped for insurance outside their job, and 67% have been uninsured for 2 years or more. And these are the people that were used in the focus groups and to find our national findings. And so our goal really is to move people, right, from feeling overwhelmed by all of the information and confused and worried to moving them to have the facts, feel comfortable with their options, and knowing the process that is up ahead of them. The key findings that we found across all segments, all populations, and our research found that these were the things that people cared about the most. Almost all of them believed that health insurance is necessary. There was no group in population and age, gender. Nobody thought that health insurance wasn't important. That was something everybody could agree on. Affordability is one of the biggest barriers to people enrolling. They just think they can't afford it, that's not for families like them. And that financial and health security are the biggest motivators. When you tell them this means health security for your family, you don't have to worry about a broken bone ruining, taking you to debt because you can't afford to pay for your son's broken bone. That was the biggest motivator for families to consider looking for options. But we still saw that there was deep skepticism and confusion among all populations that were that we researched. However, these were the 4 top key messages that reached the most uninsured. So this was a top message that 89% of the population, again across all segments, these moved the needle of motivation. So you could be, so that means that anybody that you talk to, if you use at least one of these, you know that it'll move their inclination to find out more information or motivate them to get insurance. So you might be able to help, get help, financial help to pay for your health insurance plan. We know that addresses a financial barrier, letting them know. A lot of these are really specific in the way they're phrased. So you don't want to say, I would say financial help, that there might be financial help instead of saying you'll get a discount or you might pay close to nothing. One of the things that worked really well in the focus groups and the research is that people don't want to be lied to, and they don't want you to tell them, oh, it's going to be so easy, and you're going to go and apply, and you're going to pay close to nothing. So saying these messages in this way was the most successful. So saying you might be able to get some financial help. And then, of course, addressing just the health security. All insurance plans now have to cover doctor's visits, mental health, substance abuse. Telling them these things, those 4 categories, touch somebody in some way. And, of course, the pre-existing condition one is just, above all, one of the greatest messages, and people feel really secure about that. So what is the timeline for getting health coverage? Of course, everybody knows that open enrollment started October 1st, and that if you enroll between now and December, your coverage starts January 1st. Regardless of your income, and whoever's applying, there will be a plan that fits their budget and their needs. And again, the financial assistance and the subsidies depend on the income of the person that's applying, but they'll be able to get more information and really find out what that will look like once they're ready to apply. We have heard so many different stories from the people that work on the ground that are helping people enroll, and the difference is just so varied. We heard one story of a woman that had type 2 diabetes, had never really been able to afford health insurance, and she came back to us and told us, I was able to enroll, and I think her premium was $1 and some change. So, just so many things go into play, from your family size to your income, but we've seen it vary from $126 a month to $1 and some change. That is by far the cheapest plan we have ever heard of, but you can see that, people that really need the help will get it. And really, if there's one thing that you can take away from this, is that for the first time, comprehensive coverage is available for all Americans, and it's based on their income, and they'll get some help, hopefully paying for it, and they no longer will be denied for pre-existing conditions, and that's huge. And despite some of the skepticism and what people feel that they're scared that they might not be able to afford it, the fact that people have been waiting for years to be able to have some help, or just not be denied for a pre-existing condition, whether it be cancer or a hernia, that's huge. And so we've heard a lot of really great stories with people out there. So this is just an example of the coverage. And I do also want to note that coverage starts as early as January 1st, but it will start later if they enroll after December 15th. So December 15th is sort of like the deadline if you want to get an insurance by January 1st. So just to note that. But then, of course, they have up until March to get insurance before open enrollment closes. And so this is just kind of illustrates the states that expanded Medicaid and states that don't expand Medicaid, and those gaps in between and how they're being filled in. And just to go over some of what is defined as an essential health benefit that all plans must cover, including preventive services. And this is really key and huge for women, right? You see number 4 is maternity and newborn care, this includes if they're breastfeeding, just everything that for a well woman, a visit is covered now, they can't be denied. And this includes mental health, substance abuse, so just really key things that people were having to pay a lot of money before, and this is now covered under essential and preventive services. And so I wanted to set the stage a little bit in the enrollment opportunity for women and specifically survivors of domestic violence. We know as part of the challenge, as was mentioned at the beginning of this presentation, that most survivors are going to be women and their children. There's going to be they're more likely to face financial distress. There's limited access to health insurance if they depend on it from their partner, and so if they leave their home situation, there's limited access. And that becomes then, you have limited access to child care. Depending on the situation, you might need mental health counseling. So there's just a lot of challenges that can be addressed. And so with the enrollment opportunity, we can really help reach the women that we know now can't be denied for health insurance. And I know that, and I'm sure a lot of you will know, is that a lot before this, a lot of victims of domestic violence or violence in general or abuse were able to be denied based on the fact that they had been in a relationship where they were experiencing domestic violence. And so, of course, now they can't be denied, and that can't be used as a pre-existing condition. And so that's huge. That's a huge opportunity so that they can get preventive care and then get screened for domestic violence, and they can get the care that they need afterwards. So now we're going to go into the enrollment process, what the public perception looks, what people feel about it, and what you can do to provide some help. So 1 month into open enrollment, and where do we stand? We honestly are at the highest rate of interest. Federally facilitated marketplaces, there's 17 million unique visits to healthcare.gov in the first 2 weeks alone. So we see people are trying to get the information, they're looking for places to find it, and individuals are getting the help so that they need. There's so many, we call them navigators or certified assistants, counselors, but these are really healthcare guides, right? And thanks to the continued work of those people, there's been improvements in day-to-day consumer experience from people being able to apply and get through the whole enrollment process. And so these, the 17 million unique visits were reports from HHS, Health and Human Services, and a lot of the wait times have drastically dropped. Some people can wait up to 2 minutes on the line before they get help, but really buying insurance is a thoughtful decision, and many consumers are taking their time, considering their options. So if you hear on the news that, people are waiting a long time and that maybe they got bugged off the first time that they went to healthcare.gov, what we're really seeing is that doesn't stop enrollment. People have been waiting for this for years, and yes, we know it's frustrating. We feel the frustration, but we know we hear it all the time, and we know people understand that it just takes patience, and they'll go back and they'll try again, because 2 hours trying to enroll beats waiting years without having health insurance. So we've really seen a lot of great interest. And so, consumers have a lot of different ways to connect and have help. And so no matter where they start, we see that there's a lot of options. You can have the online option. There's by phone, in person, using a paper application. The systems all are data-driven, and they integrate eligibility across programs. So you give basic information about yourself and your household. It asks you for contact information. It asks you who's applying for coverage. It asks you for the different income types, number of people in the household. It does ask for citizenship and immigration status. It asks you if you have affordable care now. Let me go over all the other things. And so, again, this is like a big process, but if somebody is ready to enroll, there are a lot of people that can help you prepare for that step. So they'll tell you if you need your Social Security on hand, if you need pay stubs. So there's a lot of different ways that somebody can prepare for the application process so that somebody doesn't feel overwhelmed and have to just have everything ready as soon as they think they might be interested. So that's really good to know. And this is just taking a closer look at some of those options that I was talking about. Online is, of course, the healthcare.gov. The hotline is where there's a person that will pick up in real time and discuss eligibility and give you a little more background on what you might need if you're ready to apply. And then there's the paper application. And the application must be mailed by to HHS by the consumer. So if a person, let's say you work at a community health center and you have a navigator, which is a healthcare guide. Really, they're certified to help somebody apply for health coverage, and they have paper applications. They have to be there to complete the whole process. So the person can't start and then leave and then have the navigator finish for them. They have to be there in person and to kind of give the seal of approval that the navigator can then mail the application for them. And usually the time has been that they will be followed up with approximately 1 to 2 weeks after that. So we do think that the fastest way to probably process an application is online, but if someone is hesitant or, the best way to reach somebody is by having a live person, and, some people are uncomfortable doing something online, we know that paper application is just as good. And this is just some of the words that I was using before, the navigators, certified application counselors, in-person assisters. These are all types of in-person assistance, right? And they, I think they're still getting, I wouldn't quote me on this, but I think there's still, people can still apply to be a certified application counselor through their organization. So I would, if your organization is interested in doing that, or you as a person based out of your organization or your business want to be one, I think the HHS is still taking applications for that. And there's different distinctions for each that all go into it, but they're based in community-based groups. It can be a health center, grassroots organizations that want to take that extra step of not only educating consumers, but then helping them enroll. So it's really just anybody that wanted to take that step forward. And so here's just a little glimpse of like what they're doing, how they're doing it, things that, you know, I just talked about. It can be in-person, email, chat, who's doing it. And we see, just from the numbers and kind of how people are enrolling, that people by far want in-person assistance more than telephone, email, and chat. And I think it just goes back to that comfort level. People are confused. They can feel worried. So 75% of people want help in person, which makes the navigators and CACs really a wonderful asset to have in your community or know where they are. Of course, the value of the in-person assistance is that, you know, knowledge is an important factor, and they just feel like they have a real service experience instead of having to do it by themselves online. And so these are some of the differences between CACs and navigators. Navigators have to conduct outreach. It's kind of like more of a job description where they have to be culturally accessible. They have to provide services for people with disabilities, and so do CACs, but you see like there's more of on things that the navigators have to do, or the in-person assisters, than CACs. And so moving on to Section 4, who are the people that we talk about when we say who the uninsured are? What role do you play, the exciting part, and then what in-reach, outreach, and enrollment best practices we have. So there's 5 clusters of the targets of the uninsured, and the demographics we're most interested in, and this, you know, it's not, it depends on the state, right? The exchanges are different than people than states that didn't expand Medicaid. But when we're going to be delivering the messages to everyone, not just the uninsured, but also underinsured and insured people that want to share the message with people that they might know that are uninsured. But these are the 5 clusters. We want people that are definitely uninsured and are uninterested. We know that these are the groups that will be a little bit harder to motivate. The ones that are reluctant, but we have some sort of information to reach them. So maybe we worked with community centers or community health centers that have more information on where people that don't have insurance are, so that they're a little bit more reachable. There's a desperate and the believing, and then, of course, connected, low-income women, and then insured but at risk of something that will have some barriers. So I would include definitely, you know, if a woman is in a relationship and she has insurance, but she's at risk of losing it depending on whether she decides to leave the relationship because of domestic violence, I would consider that population insured but at risk if they are insured. And so these targets came out from the research. So the national findings found the populations lied in one of these clusters, and I'll go ahead and explain that a little more. So the uninsured and uninterested are 71% are uninsured. So it compiles most of the group of the uninsured. Only 22% consider health insurance necessary, and they're skeptical, of course, about affording coverage. But the good news is that with the right motivators and with the right messengers, we still found them to be movable and motivated to get insurance. And so, of course, we go back to the top motivators that were in one of the 4 key messages, is that financial security, you know, that they won't go broke if something happens in their family, like a car accident, that they might get financial assistance. It addresses the financial burden. And then the individual mandate. This is the least of the motivator. So like if you tell somebody you'll get a fine if you don't enroll by March, that doesn't work as much as people think. So I would avoid that message. And then of course best messengers, the doctor, somebody who did it like them, family. So that's great. If you reach a couple people, you know that they're trusted messengers in their family, you know that they have friends that they can talk to. And then there's the reluctant but reachable. And so these are the young, low income, least educated of the groups. Most have young children in Medicaid. So this is a really interesting population. We realize that we can do a lot of work in community colleges and programs that help with WIC and CHIP because you're trying to reach the young, low-income parent. So, you know, a lot of parents did everything that they could to make sure that their kids got were protected with CHIP, but a lot of them didn't qualify themselves for health insurance. So now it's going back and reaching those parents that got their kids covered under CHIP that might be now eligible for some financial help and subsidies. So there's soft believers, meaning they can be moved pretty easily, but they're not outright going to be looking for the exchange. They're not the ones that will necessarily go to healthcare.gov on their own. Their top motivators are as well, reliable coverage. This is something that your family can depend on, finding a plan that fits their budget, security. And we see, again, it's the doctor, somebody like them who has tried it. If you have volunteers from the community that you're trying to reach and you train them with key messages, it's somebody like them. They live in the same neighborhood. They were able to find enrollment. They're telling them this is important. And, of course, kind of like the group before that trusted a doctor, they trust someone from a health agency because they consider them an expert. And so that's really service providers, nurses, somebody that has some kind of really legitimacy. Then you have the cluster of the desperate and the believing, right? And they're the most in need, and this is why they believe. They're the poor, the sick. Most of them are in receiving SNAP benefits. They have the strongest interest because they know what it's like to go without health insurance, right? And so they have the stories of that they've had experiences where they needed it and they didn't have health insurance. This is the heaviest Latino sector, and it's also, of course, as it says, they're one of the poorest. They, as we would say in outreach, they're the low-hanging fruit in terms of convincing. You could have one good conversation, and it doesn't take more for them to sign up for more information. Then, of course, you see the same top motivators. And then the connected low-income women. So 60% of this cluster is connected to Medicaid, either for themselves or someone in their household. Most likely it's a child. This is the lowest income sector. 77% are probably going to be Medicaid eligible. This group sees health insurance as necessarily, usually overwhelmingly. Women are easily motivated because they have children, they understand they're the ones that understand that health coverage is important as just health safety, really. And they're one of the two top messengers it's interesting because they're messengers to each other for women, so someone like me that traded a girlfriend and a partner. But really across all sectors, most people saw mothers, girlfriends, spouses, and partners as their best messenger. So we really find that really key in a lot of our outreach work is trying to get women trained as key messengers because we know that women tend to be better in outreach. And then you have the insured but at risk. And so these are most of them have insurance, but they're teetering on the edge of self-identified as being at risk of losing it. This tends to be a young cluster, so perhaps, maybe you're 25 or 26 already, so you're insured, but you're about to lose it because you're going to get off of your parents' insurance. So it's just, this is like a more difficult, challenging group to get at because they're not as desperate. They have insurance, so they don't see the urgency in getting more information. So why do we reach out to groups like health centers, rural health clinics, service providers? These are who people trust, even insured patients, right? They have relationships with doctors and providers. They're in communities that even with a strong, aggressive grassroots campaign, we're never going to reach the communities that people are already based in. You have the relationships, and you're already trusted naturally by the type of position that you have. So what are the enrollment opportunities? What role can you play, your organization? What are you doing? What tools are out there, right? Now that you have all this great information, now what? So the first is really getting yourself familiar with healthcare.gov. How do you find those navigators that we talked about, the CACs? And the first thing is to really familiarize yourself with your community, where they're located. Localhealth.healthcare.gov helps by zip code where they are in your area, and so you can find the in-person assisters that you can maybe recruit to go to an event, do an enrollment event, or just have to go talk to your friends, loved ones, community, a block party. Where can you get these people so that they can help reach as many people as possible? And so what's your role? There's definitely different ways. A lot of these ways we've already partnered with organizations and individuals that want to help get the word out. So let's say we have one organization that is, let's say, interested, but they don't want to invest a lot of resources. Maybe they can just hang up posters in the waiting room if it's a clinic, right? So let's say they don't want to train their staff. The easiest thing you could do is have some sort of printable information in a space where people will see it. So maybe you don't have a business, but you frequent a small business in your community that you know has a high traffic. Maybe forming that relationship with the person or the owner and asking them if you can just leave some information by the register, just something very easy. An example of another organization, let's say you're already engaged and you're active, but you want to do more. You can become a CAC. You could partner with organizations in your community that are already doing enrollment to help either recruit people, get the word out. And let's say another one. Let's say you're currently providing application assistance and you're actively conducting outreach. The next step would be to monitor, evaluate, and follow up. And there's some best practices around that, and we'll kind of talk about that. So there's a difference in in-reach and outreach ideas. Outreach is definitely if you have the capacity and you are built into a community that sees a lot of consumers, right? A lot of, in the day-to-day basis, there's a lot of new people. In-reach is more, for example, a member-based organization, somebody that only has online capacity. And here are some of the ways that you can get the word out. You can get a text message service, newsletter. Direct mail is probably the least effective and more expensive option, but using websites, social media. GetCoveredAmerica.org, which is our consumer-facing website and for our educational campaign, has it's a partnerships and action resource page, and we have tons of online graphics, memes, widgets that you can use on your page. And then there's toolkits so that if you want to do outreach and enrollment events, and so that you can partner with organizations, engage your faith community, tons of things that you can do. And so just, again, driving back the key dates, enrollment period is October 1st to March 31st. But if you want coverage to start for somebody for January 1st, they have to be enrolled by December 15th. So we will definitely see a peak in just awareness about this and driving people the first weeks of December, because December 15th is really kind of the cutoff if you want coverage for January 1st. And just really quick to kind of talk about Medicaid tips, just in case you're not aware, when you are enrolling for health coverage through the marketplace, if you qualify for Medicaid, it will tell you. So let's say you're in the middle of it, it detects, because it uses several databases for information, and it's trying to find what kind of subsidy you might qualify for. If you don't qualify for a subsidy but you qualify for Medicaid, it alerts the navigator, or if you are doing it alone at home, it'll let you know. And so that's it. If you want more information on best practices, outreach and enrollment, we have departments that work on this. We have toolkits, mapping tools. We have the new calculator. So it's a really easy to use tool that it asks you some basic information, and it'll kind of give you an average of what your premium might be. So you put in your state, household income, how many people are in your family, your age, and it gives you a pretty accurate estimate of what your premium might be. And so again, that's getcoveredamerica.org. But that's it. I think we're going to move on to questions probably.
Yes, thank you, Amber. This was really great information. I want to let people know if they want to ask questions, they need to unmute their lines by pressing *1 if you are calling in, and I will unmute the lines manually who are calling in from our internet. So if you might bear with me. It should be unmuted, not muted. That's not helping. There were a couple questions that came up in the meeting chat, so I can pose that to you.
Okay.
Oh, sorry, we're getting some background noise. All right, we may have to mute everyone on the computer end. If you have questions, please use the meeting chat box. We're getting a lot of background noise. Okay, that helps. Sorry about that. Amber, one of the questions that was raised in the chat box was, after January 1st, can people still apply? And a follow-up to that was, when are people penalized for not enrolling?
Depending on your income, and sometimes people will say, well, I'd rather pay the small fine maybe instead of getting health insurance. But the truth is, some of the things that I often say when I'm doing canvassing or talking to people, it's like, well, do you want to pay a fine for nothing, or do you want to be able to pay a very small price and get health insurance, right?
Okay, and another question I saw, Amber, was regarding healthcare.gov and the available languages. You see that Spanish is available, but what other languages options are there? And if they're not on the website, where can people get assistance?
Yeah, so in phone and chat, there's help available in more than 150 languages. So you just have to request for the language that you prefer. But yeah, there's assistance in over 150 languages.
Oh, no problem, hon.
Are there other questions? I'm seeing one more. One is about the Medicaid expansion. For those who are in states that choose not to expand Medicaid but fall below the subsidies, what options are available to them?
Yeah, so that can get pretty tricky. You, of course, still want to move everybody to apply in the open marketplace. It'll give you the options in state by state, so it varies. I also know that community health centers are a really great asset in this because they will take anybody really that maybe there's some gaps, right, in the states that maybe somebody will be left out without the marketplace insurance or Medicaid. And so community health centers are really taking up that bulk, and if you have nothing else, they have to see you.
I'm also seeing someone ask a question. I'm a client advocate for domestic violence sexual assault survivors, and most of them come in saying they do not have health insurance. Does that mean those who apply for Medicaid, that they are not denied?
Oh, are you reading the one? I'm sorry, it's hard to
Sue Williams, yes.
Let me just read it. So is the question, People are coming in saying that they don't have health insurance. Does that mean those who apply for Medicaid are not denied through the marketplace? Is that the question?
If you're able to, yes, that's the question.
It's not for certain. It depends. So they would still have to go through the marketplace, and depending on the state, if they were denied for Medicaid, they might be able to get a better subsidy on the marketplace, but it's just hard to say. Like, they have to go through the process. It's not if they're denied for this, then they get this.
Okay, Sharon. We're not understanding.
And I know, Amber, you had mentioned that the navigators and others who can assist. Are they typically able to go to different organizations and support clients there?
Yeah. So, I mean, if you're in one of our states and you want, one of our organizers to have some event and help out, please definitely email me or go to our site, and somebody will help you go to an event that's already happening in the community. But the way that we've done it, and we've worked with organizations and coalitions in the states where we don't have staff, is that, let's say you organize an event at a library, and you're going to invite your organization, maybe it's just a member organization, and you want them to get more information. A lot of people have done enrollment events where they reach out to a navigator and you let them know you're having this event and you would like for them to join. Either for one of two things, they could do enrollment on site, so you can give them a little bit background about the ACA and their options, and if they want to stick around, then they get enrolled with the navigator on site. Or a more popular one is that the navigator then does appointments for the people so that they can follow up with them in the coming weeks.
Great. And I'm seeing a couple other questions. One is from Allison Smith. She's in a state that has not chosen to expand Medicaid. Has a question about what to do with this. Are they going to be penalized? Are they under some sort of exemption? What would be the best advice for her?
Yeah, so people won't get, there is an exemption. If you live in a state where they didn't do Medicaid expansion and you go through the process, there's actually several things that give you a penalty exemption. I know one of them is if for some reason your religious background kind of denies you the opportunity of applying for health coverage. There's a process for the exemption, but you have to prove that you were denied for, let's say, I live in a state that didn't do Medicaid expansion, I couldn't get a subsidy. They won't fine you. If your religious background denies you the opportunity to do that, you can also get an exemption. But healthcare.gov definitely has more information on the process to follow to file for an exemption.
Great. And when would the penalties start to kick in?
So after March in 2015.
Great. Are there other questions? Oh, yep, I'm seeing Allison's following up. But can a state be forced to give Medicaid to those who are eligible?
Not if the state didn't choose to expand.
And I think a couple of my colleagues were talking about this in the past. When Medicaid was first put into law years ago, many states were hesitant to expand immediately, but eventually it did happen. Unfortunately, that does not help those who are in desperate need of health coverage right now, but we're seeing more and more states are considering expanding their Medicaid program.
Yeah, and you see them more and more we've seen the states kind of changing. So it's a good thing. More states are deciding to expand. So that list is definitely growing.
Yeah, and in response to Allison, even if they are eligible under regular income limits, unless they fall into the specific categories that the state currently covers, they would not be eligible. Is that correct, Amber?
Right. Yes.
So that's a great opportunity for advocacy at the state level to make sure that you're pushing that the governors and the legislature do expand Medicaid. Any other questions?
If there's more, and I will say, a lot of these things get kind of tricky, and it really varies between state to state. So if there's specific question to your state and kind of how that the limits go and what happens to the people that kind of fall in the cracks, definitely feel free to email me. I can point you to the right direction. We have our Best Practices Institute that is really the brain behind policy. So let me know.
Thank you, Amber, so much for your time today. We're going to be sharing the PowerPoint and a recording of this webinar for everyone who signed up and registered for the event. You've shared some fantastic information, and we hope that we can help continue to expand outreach and get people signed up for health insurance. Amber, you have your contact information there, so hopefully people can reach out to you as well. But thank you again, and please, everyone, join me in thanking Amber for her time and her great information.
Thank you so much. I hope this was helpful. Thank you.
Thank you all. Have a wonderful afternoon.